Good afternoon, my relatives. My name is Clayton. I am the traditional knowledge holder at Wapan Benez. They've asked me to do a traditional opening, an opening prayer, just to let everyone know if we would be doing this in person and we'd be in a circle, we'd all be together, but due to restrictions, we cannot. So I'm just going to do this opening, and it's been challenging for the last year or so to do these, but I'm getting okay at them, I think. All right, so invite spirit into all of this. So I just want to say miigwech, and I just want to say thank you for coming here and just listening to our sister talk and share her knowledge with us. So with that, I just want to say miigwech. I just want to just to say miigwech to our first mother of all mothers, our mother, the earth. Again, I send my prayers to her. I pray to her again and again. I pray for her in gratitude for everything she provides for us, the people. We come together as the people, and we say we acknowledge her. I acknowledge her, and we say thank you for all the medicine she provides for us, for us, the people, and our relatives, the four-leggeds, the crawlers, the swimmers, the flyers. In gratitude, I say miigwech to her. I say miigwech to Father Sky. Again, I partition. I ask the spirits of my ancestors, those beautiful ancestors, your ancestors, wherever you are, to be with you, to guide us physically, mentally, spiritually, emotionally, in a good way, in a kind way. In these very difficult, challenging times, we come together as the people, and we say thank you to our ancestors, those good ones. So with one mind, one heart, I say miigwech, I love you, I say thank you. I offer my prayers to the sun, grandfather sun, for a new day, a new beginning. You are setting, and again, I partition to you will return, grandfather sun, for bringing the light, for bringing the warmth, for making the medicine grow for us. I say thank you and our relatives. I say miigwech to you. I say miigwech to Nukamis, grandmother of all grandmothers. Again, I send my prayers, my thoughts to you. I love you. I say miigwech to you, Nukamis, grandmother of all grandmothers, for doing everything you do for us, for putting the waters, the rivers, the lakes, the oceans into order for us. We come together as the people to acknowledge this, for water is life. I remember this at this moment. So many of us, so many of our brothers and sisters have forgotten this, but we come together and the people, and we acknowledge this moment in gratitude, for water is life. I say thank you, Grandma. I love you. I say all my relations to you. I offer my prayers to you, great mystery, creator, again, creator, just a man. I stand here and I say to you, for there is nothing beyond you, creator. I say thank you for this gift. We come together as sisters and brothers, as relatives, as the people in this circle, and we come together to listen. We have good thoughts, good heart. I say thank you, and I ask you again and again for the blessings for all of us in these difficult, challenging times. I say thank you again, Creator, for this beautiful gift you called life. All my relations. Miigwech, miigwech, miigwech. Simple prayer, guys. And it's just thank everyone for coming. All my relations. Miigwech.
Thank you, Clay, for that wonderful opening. I'd just like to welcome everybody to the Ontario NEIHR December webinar. Today, Dr. Brenda Restoule will be speaking to us. Brenda is from Dulcus First Nation and from the Eagle Clan. She's a registered clinical psychologist. Dr. Restoule is the Chief Executive Officer of the First Peoples Wellness Circle, which is an Indigenous-led national organization dedicated to raising the profile of Indigenous mental wellness using Indigenous knowledge and evidence. Primary work of FPWC is implementation of the First Nation Mental Wellness Continuum framework, to which she is co-chair of the implementation team, and developing a network of supports for mental wellness teams across the country. Her work spans from providing clinical and consulting services to First Nations communities in Anishinaabe territory, to consultation with provincial and federal governments on Indigenous mental wellness, to an invited trainer and to an invited trainer and speaker, to authoring book chapters and training manuals. Some of Dr. Restoule's past work experiences include includes the Royal Commission on Aboriginal Peoples and working with federally incarcerated Indigenous women, children's mental health, and urban and First Nation mental wellness programs. She has particular interest in cultural safety, First Nation community development, capacity building, and reducing suicide rates in First Nation communities using First Nation knowledge and practices. Dr. Restoule, welcome.
Miigwech, thank you, Roy. Ani Bojo, Wabsaquestijnakas, Magisi Dodam, Okikanda Donjaba, Anishinaabe and Dao de Bendigo Saking. I'm really happy to be here today, and I appreciate the time that you've given to spend with me as I talk to you a bit about the First Nations mental wellness continuum framework, and mainly to talk about how do we implement the framework. And so okay, sorry, just going to get the slideshow up here in front of our screens. There we go. And I often hear folks who are aware of the First Nations mental wellness continuum framework talk about the complexity of it and the sometimes how difficult it seems to think about how do we implement the framework and what are some practical applications. And so today I thought I'd spend more time talking about practical applications of it in communities, through policies, through service and program delivery, as well as through systems change. Without knowing who my audience all is, I'll spend a few minutes just talking about the framework. The First Nations Mental Wellness Continuum Framework was a framework that was co-developed as a shared vision to look at creating a First Nations mental wellness vision. That co-creation and co-development occurred with some main partners. It included the First Peoples Wellness Circle, Thunderbird Partnership Foundation, the Assembly of First Nations, and the First Nations and Inuit Health Branch of what is now Indigenous Services Canada. They were under Health Canada at the time. That work that we embarked upon really was intended to build upon existing conversations and work that was happening in the different regions across the country around mental wellness. And we didn't start at the beginning, but we started where that work was already happening and went back into our communities in each of the regions. And we spoke with over 600 First Nations voices across the country and asked them to tell us about what they understood about about mental wellness in First Nations communities, and what they saw as what might be needed, what was missing, what were the gaps, to help us really to create the framework. Ultimately, the framework was created and launched in January of 2015. It was launched through the Assembly of First Nations, and it currently can be found on the Thunderbird Partnership Foundation website. And I do have some links at the end for you, should you be interested in those links if you haven't read or know much about the framework. The framework outlines a coordinated and a holistic approach to mental wellness programming that takes into account the critical importance of First Nations culture, tradition, and language. And in fact, the framework notes that culture must be foundational to mental wellness, for without culture, we cannot achieve mental wellness. The intention of the framework is to do a number of things. Ultimately, it's meant to be to support systems change for improved well-being of Indigenous and are mainly First Nations people. It also does a couple of other things. It's also meant to link and create a more holistic vision of well-being, both mental and physical health, emotional and spiritual as well. When we did the engagement across the country, and we were completing the development of the framework, we heard from many people in our communities that what eventually was created looked more about well-being or wellness. And there was some ask that we remove the term mental wellness because it appears to be sometimes seen as stigmatizing or concerning. Makes folks feel uncomfortable to think about it from a mental health aspect. Unfortunately, we we didn't do that. And the main reason was because the Assembly of First Nation, our partner, reminded us that when we went across the country, we asked questions specific around mental wellness. And so we invited anybody who was connected to mental wellness to participate in the conversation, but there was the possibility that we could have been missing folks in those different areas, whether it be in social, housing, education, employment, etc., that might not have participated in the conversation. And so because we may have left out the voice of some folks who could contribute to the idea about well-being and wellness, we needed to stay within the parameters of mental well-being. But many continue to say that it does have applicability outside of mental wellness. So it really is meant to be holistic. It's also meant to really create a continuum of health programs and services that are considerate of the Indigenous social determinants of health. And it was created with the intention at a systems level to think about having a common language, having common understanding about mental wellness, and to use it as a way of what we say here, doing a new way of doing business. But I think really to help communities and First Nation organizations be able to advocate, negotiate, and talk with funders, government, and others about what wellness looks like in our community and how that should be delivered, how the programs and services should be delivered. We knew that communities were already doing a number of things in their communities to address mental wellness more from a cultural standpoint. And so we saw this framework as not starting from scratch, but rather building on innovation occurring within our communities around mental wellness. And finally, we saw it as an opportunity to outline the continuum of programs and services that are aligned along a population health model that can link both public health and primary care with mental well-being. This is a picture of the mental wellness continuum framework. And you can see along the outer edge that culture was identified as one of the key elements of mental wellness framework. And so this PEI red color that we have here, as you can see, flows all the way to the center. So it's meant to show that it is foundational. And then we have the next ring is talking more about the other elements of the framework. And the second element we heard from folks was it's important that we also have a piece that looks at community development, ownership, and capacity building. The third element was talking about quality care systems and a competent service delivery. The fourth was around collaboration with partners, and the fifth was around enhanced flexible funding. So that's that second ring. Our third ring looks at the Indigenous social determinants of health. The light green ring is all of the partners who would contribute to mental wellness in our communities. That dark green ring is all of the levers or the mechanisms that are required to ensure there's a shift towards First Nations mental wellness. The blue ring is the continuum of essential services. That light orange ring is special population needs. The bluish gray ring is all of the populations that get served. And then we go back to that PEI red and who are the ones who support mental well-being. And that would be our communities, our families, our clan and our kin and our elders. And that inner ring is the outcomes of mental well-being, and those are hope, belonging, meaning, and purpose. And so I'm not going to go into depth about it. You can read about it more in detail in the links that I have at the end, but just wanted to highlight for you what this ring, what the framework looks like and what all of the rings represent, and note that it is a fairly complex model. And we do have some wheels that we do give out and that are movable that help people to think about using the framework in ways that are meaningful and helps them to do create mental wellness programming from the priorities and needs of the First Nations. So one of the things, this just lists out the different rings and what's in each of them. And I would like to talk about outcomes in 1 minute, but before I do that, I just want to note that our intention with the framework was to ensure that it had applicability across the country, recognizing that that there are many different cultures, but that there would be some specific pieces that are common. And so when we talk about culture, we don't talk about it being anything in particular, but rather that the communities from the different territories and regions are able to use the framework in ways that are meaningful to their territory, meaningful to their language, their beliefs, their ceremonies, and their practices. And so it leaves it very open for the community to align the work in ways that will address their needs and priorities and are not pre-established by the framework or by funders or others. And so the outcomes, as we saw it, really was intending to recognize that mental wellness is a balance of spiritual, emotional, mental, and physical well-being. And that balance is enriched in many ways. And so we note that hope, belonging, and meaning, purpose are those main outcomes. And you see here that we talk about hope being a connection to future and those of our family that's grounded in our sense of our identity, our values, and a belief about spirit. And that when people are well from a mental standpoint, they have a sense of belonging, and that belonging gives them a connection to their family, to their community, and to their culture. And that when folks have emotional well-being, it can be seen through people demonstrating a sense of having a sense of meaning in their life. And that meaning is helping them to understand how their lives and the lives of their family and community are part of a creation and something much greater than themselves, and part of a very rich history. And when folks have a good sense of physical well-being, they demonstrate it through having a strong purpose in their lives. And that life comes from their daily interactions through a number of ways, whether it's employment, education, caregiving activities, and cultural ways of being and doing. And these outcomes came from some work that happened through the Thunderbird Partnership Foundation in a research project known as Cultures as Intervention research that was facilitated by Elder Jim Dumont, Anishinaabe elder from Shawniga First Nation in Ontario. And they asked a number of questions about how do we know culture works, and what is it that tells us culture works? So they knew that it worked, and they wanted to identify what are the means in which it works and what are the outcomes that tell us that culture works for well-being, which created the Indigenous Wellness Framework. And you can see here that they've identified how spiritual, emotional, mental, and physical well-being lead to hope, belonging, meaning, and purpose. And they have 13 indicators all noted within those blue sections that talk about how it gets expressed. And so part of our work in the framework, it came together very nicely with this research to place at the center these outcomes as part of being able to perhaps evaluate or measure well-being in our families, our individuals, and in the communities. And so we understood and heard very clearly that culture was a foundational piece of that work around establishing mental well-being. And so we saw it as one of the most critical pieces of the social determinants of health, and really brings together that holistic concept of health, where a significant part of it is around our strong cultural identity, and that we need to have all of these in place in order to have good well-being. And so by applying the framework, we've talked about the importance of making some really big, important conceptual shifts. The first was moving away from a program that focused on deficits to one of a discovery of strengths. So using strengths-based models of care and models of programming that moved away from excluding our worldview and our values and our evidence and our culture, to ensuring that our values, our culture, and our worldview were foundational to the work that we do, and that the outcome, that we would look more at focusing on outcomes for individuals and families and communities through holistic collaborative approaches, recognizing that for so long, a lot of the work and programs have been focused on inputs at a deficits-based model, and we've identified that when we invest in deficits-based solutions, and when we invest in deficits-based solutions at an individual level, we're not making significant changes in the community. We must build on strengths. We must invest in strengths and invest in those so that they create outcomes at all levels for families and communities, as well as those individuals embedded within each of those. And that we really wanted to move towards a more comprehensive planning approach that has that integrates the different levels of the government around funding and service delivery, so that we are moving away from program silos and allowing communities to adapt and realign and optimize the programs and services in their community based on their priorities, so that our approach really does strengthen a more of a multi-sectoral approach to care that connects health and social programs across federal, provincial, territorial governments with First Nation communities, so that we can have integrated care and attend to the Indigenous social determinants of health. And so how does that look in communities? Because it is really complex, and it can look really challenging to think about how do communities implement this in the communities? So here is one example. This is in the Sioux Lookout area in Ontario. They have been using a harm reduction program around a community-based buprenorphine treatment program to address opioid use. And in this treatment program they initiated, it was either by bringing in both the primary care physicians into the community, or that are supporting communities, and may also be urban sort of addictions medicine specialists that might be coming in through telemedicine or through fly-in locums. And the primary care physician would work with the addictions medicine specialist to support the patient to become stable in addressing their substance misuse. And what they found is that when they use the really buprenorphine is Suboxone, is when they use that and they have the opportunity to work with the frontline community workers like nurses and nursing stations and nurse practitioners and community workers, they were beginning to see a difference, because what the addictions medicine specialists did was they acknowledged that the strength is within the community, because those community frontline workers have relationships already with the community members who may be struggling with substance use. And so they invested by building on the capacity of the frontline workers by giving them the training to nurses and nurse practitioners and community workers to be able to dispense the Suboxone directly in the community, whereas before members either didn't have access to it at all, had to move out if they were in fly-in or remote communities, move out of the community to get access to these services, or do without. And so each community established a recovery program that included mental health workers, and the mental health workers from the community provided the counseling as well as cultural supports and healing practices. So they weren't just about addictions medicine. They provided a more holistic form of care that included involvement in culture and thought about how culture works from a harm reduction standpoint and the counseling piece, and brought all three of those together. So by creating a more comprehensive approach to care, it enabled community members to be able to stop their opioid use and return to work or school, and better engagement with families. And they found that a year after they initiated that program, they saw some reduction in things like criminal charges, less medevac transfers happening. They had a needle distribution program as part of their opioid program, or their another harm reduction program, and that those rates went down, which suggested less people were using. It went down to less than half, so they knew that the rates and volumes were decreasing. And they also saw that rates of school attendance increase for young people. And so that was one of the examples where they noted that by investing in the community and making community the hub of building capacity and recognizing the strengths of the community around culture, cultural practices, and the frontline workforce, that they could make a difference for the people in the community. So that's one example. And you can see here that there is a journal article about that one. Another one is called Widuk Tadyang, and Widuk Tadyang is from Nipissing First Nation, and it loosely translates to "we are helping one another." The intention of the Widuk Tadyang program was to go back to their strong history of taking responsibility for themselves and others in their community by helping and supporting each other, because they are all interconnected and interrelated. And it was meant to attend to community priorities by looking at Nipissing's overall strategy around developing a holistic strategy to enhance health and social services that is matched within their Chinog Nagawin, which is their big law or their constitution. And so it was guided by community members. They utilized a flexible funding approach. If you remember, that was one of the key elements, flexible enhanced funding, by using both provincial and federal dollars to develop the program. It was guided by community members. So there was both Nipissing administration, leadership, community service sector workers, and community members and their families coming together to envision and plan what Widuk Tadyang would be about. And it was seen as something that would provide a catalyst for organizational shift within Nipissing, so that there would be a more holistic use of how services are delivered to the community, as opposed to being very siloed and saying, sorry, I can't help you with that. Oh, you have this problem, you need to go there first. It was about making sure that they were meeting people where they were at, and they were empowering the workers in the community to have more competencies to support people when they come to their door. And so they wanted this no wrong door approach to service delivery. And so making sure that people got the right kind of help no matter where they ended up for services, and that the staff had a responsibility to link them with the types of supports and services that they might require. They had an interest in making sure that they were attending to some of their more complex needs that might be from their community members, particularly those that they saw were more vulnerable or who might be falling through the gaps and in care. And so what they did was they provided training to all service sector staff across Nipissing. So it wasn't just those in health and social service. They made sure it was employment, education, culture, housing. They even did the public works department. They did they have a ministry of natural resources, or they have a natural resource department, I should say. So they did the natural resource department, the lands department, the membership department. They did every department because they recognize that sometimes people end up in other departments that aren't necessarily in the helping sector, but require some support. So for example, we have seen that our men between the ages of 20 to 50 often are fishermen, and some of them struggle with substance use. And so they have their most contact with the natural resource department. So we wanted to make sure that those staff who recognize folks were struggling with, let's say, substance use, had the language, had the ability to talk to people and connect them to the services they need if they were struggling with substance misuse, housing, financial needs, etc. And so they really saw that this was more than a process, because they wanted to be able to reinforce the Anishinaabe identity and draw on their cultural and traditional strengths about ensuring that they were providing holistic services and attending holistically to the needs of their members, and helping them to connect and get access to a bundle of supports and services to realize well-being for their membership. And so they wanted to make sure that their services were approachable and that they were improved to meet the needs of the community as a whole. And so there was a lot of benefits seen. They saw it as ensuring that there was better alignment with culture and the vision of the nation around service delivery. They wanted to make sure that there was a closer fit and sticking ability from a community development perspective, so that it was going to be sustainable, that it was based in culture and strengths and family based and holistic in nature, that departments and the staff were able to gain knowledge and skills to enable them to better serve the folks that they work with, and that the approach ensured that all departments were supporting the strategic plan of Nipissing, and that there was an overall cultural shift, as I mentioned earlier, within the organizational culture, and moving really away from what the external or funding agencies said had to happen to more of a community orientation about what was their priorities. And finally, making sure that families and individuals were benefiting from these bundled service and in a more integrated model of care through the training and other means. And so I'll give you an example of how it was used. This gentleman he's 62 years old, and he has issues he has an alcohol addiction. He has a number of traumas in his life and in his family's, his parents and his grandparents' life. So we can say that he has intergenerational trauma. He had housing issues. He was living in a home that had been condemned, and so there was no heat or hydro in the house, and he was heating it with propane heaters, and just sort of living with lanterns and things like that. He was living in poverty. He was unemployed at that time, and he had a number of family issues as well as chronic disease, mainly diabetes. And so they started very simply with him. What they started with was acknowledging that he had an addictions issue, but that when they talked to him, what he was interested in was getting a job and having some financial security. And so through the Ontario Works program, they invited him to a work program. I think it ran over 16 weeks, and they said, we'd like you to come to this program and we'll give you a job. And he was very eager to do that, but they recognized that often his alcohol use got in the way and he wouldn't always come to work. And so they set it up that he work with somebody who happened to be a family member of his and a staff in the Ontario Works program. And he would have to come in and meet with her every day. And she would assess him to see if he was sober or not. And if he was sober, she would give him tasks for the day. If he wasn't sober, without judgment, she would just say to him, you know what, today we don't have anything for you, or it sounds like maybe you had a rough night and maybe you're not really ready to work today, and just acknowledge that, you know, his addictions might have been getting in the way, and tell him to go home and to come back, you know, maybe that afternoon or the next day, depending on her assessment of him, and they would try again. And so they found that from the beginning to the end of the 16 weeks, that at the beginning he was coming 1 or 2 days a week and being able to work, and by the end he was working 5 days a week, and he was choosing not to use alcohol so that he could go to work. And so we saw that as a positive. He also was just given a lot of the sort of public work type of tasks in terms of cleaning and sweeping and taking care of the community buildings. He took a lot of pride in that, and people just started to engage him. They were happy to see him. They'd say, how are you today, Robbie? And he really kind of took to that. And they also found that the money he earned, he saved. So he didn't have a car or anything like that. So he saved it, unlike others who were using it to buy substances or sort of fuel their addiction. He was saving it, and he saved it, and he bought himself, I think if I remember correctly, he bought a skidoo for that winter to get around. So he got a means of transportation, and he liked to cut grass. And so he bought a lawnmower because he wanted to make some money in the summertime. And so they found that when the program ended, that he kind of returned to his alcohol use. And so because he had developed relationships, they created a bit of a team approach, and they talked about a lot of these concerns. And what they started to do then was he built relationships with the addictions counselor, and she talked to him about his needs. And he said, I don't ever want to quit drinking, but he wasn't opposed to reducing his drinking to make sure that he got what he needed. And they said, what is it that you need? He said, well, I'd like to have a job. And when they talked more to him, they said, we're concerned about your housing, because they didn't know how well he could take care of himself, because we couldn't bring any services into a condemned home. And so they said, would you like a house that maybe has running water and heat? And he said, yeah, I would like that. And so as a team, they created some opportunities and worked with the housing program, and they got him into a rental. They knocked down the old house to make sure that nobody was harmed, and they put him in a rental. They got him onto Ontario Disability Support Program because of his addiction. So he got a more of a financial income, and that was more stable. And he identified that he still wanted to work. And one of the things he wanted to do was to run like a lawn care business. And so they began to work with him on that, and they connected him to the employment office, and they helped support him to get a small business loan. And he bought a riding lawnmower, and he started a lawnmower business, or lawn care business, I should say. And they noted that it just created a sense of hope and a sense of pride and purpose in him. And they also noted that they had been trying to work with him on his chronic illness around diabetes. And they had these diabetes care clinics where he would have access to optometry, nurse practitioner, mental health, addictions, diabetes care. And they were holding those on a quarterly basis, where they would look at his records and make recommendations and work with his primary care physician. And he had never been able to come in because of his alcohol use. And so as they got him more stable, he came to one of the clinics, and what he shared was, I went last night into town, because Nipissing is semi-urban, and visited with my sister, and she wanted me to stay and have drinks. And I told her I really couldn't, because I had to go to this clinic the next day, and he rides a bike. And so him and his sister negotiated that he'd stay, he'd only have 5 drinks, he'd sleep overnight, get up early, and drive his bike back to the community for the clinic, and did so. So we saw all of these as things that were really, really helpful. We also wanted to engage him in the community. So the other thing was, we helped him become more engaged in some food security. And so as we were transitioning him to his own home, we said, we have a good food box, and we need help getting that good food box packed and delivered. Could you come in and help pack it? And he agreed to do so. And we'd say, oh, thanks for coming, here's a good food box for you, because usually there's a small stipend to buy, like to get it. And so we would say, because of your volunteer, you can get a good food box. We were making sure he was getting good food to help with his diabetic care. The other thing was, we have a diners program for those over the age of 55, and he was over 55 and he wasn't coming. And so we said, we need help serving, could you come and help us serve? And he agreed to do so. And we said, why don't you come a little bit early, just in case we need some help setting up? And so he'd come early, and then they would say, oh, you're here early, why don't you have a plate of food before you help serve? And I think the second or third time he said, okay, I'll take that food. And I know you have me here because you want me to eat, but that's fine, I still want to help. So we were really helping him to invest in what he thought was important, and that was connecting and being helpful to the community. So those things, again, gave him a sense of purpose, but it also gave him a sense of connection to community. So in all of those ways, it gave him that sense of hope, that, you know, that he could have a business, that he could earn his own money, a sense of belonging, contributing to the community, meaning in his life, and purpose. So just a really nice example of that. Here are some service examples now. Practical application and service delivery, I think, is one of the things. So mental wellness teams exist across the country. Many of these mental wellness teams provide services to a small group, or maybe even a tribal group of First Nation communities. And those communities identify the priorities that they have, and they set up these mental wellness teams to meet those priorities for that small group of First Nations communities. Many of these mental wellness teams use both traditional cultural supports like elders, cultural support workers, along with frontline workers, and some mainstream services like psychology, social workers, psychiatry, even nurses. And so this is a practical application where mental wellness teams are created based on priorities of a small group of First Nation communities and use the continuum of care around supporting the membership in whatever the priority need might be. And so they differ across the country. So that's one practical application of how the framework is put into practice by communities owning, developing, and designing and building the capacity within their communities to do that work, and then creating their own quality care system to meet their needs. Another one has been land-based programs. We know that many of our land-based programs have culture as a foundation to that work, and it is very much grounded in the land, in the values, the practices. And so that service delivery model we're seeing happening more and more across the country. In fact, during times of COVID, we have seen a significant increase in communities looking at different types of land-based programs. Some of them are to support folks who have substance misuse issues, some are around trauma, and some have been about helping those who are precariously housed, so those who have homelessness issues, and getting them out on the land and helping them to feel like they have a place to be, especially when COVID first hit and we wanted to make sure that people weren't sleeping on the streets or couch surfing. And also the whole notion about strengths-based programming. And so there is some work that was done by First Peoples Wellness Circle with Thunderbird Partnership Foundation and a Pan-Canadian health organization previously known as the Canadian Foundation for Healthcare Improvement. And they were looking to do a collaborative where they work with Indigenous they work with non-Indigenous health authorities who had identified that they wanted to do work on suicide prevention in First Nation communities. And the Canadian Foundation on Healthcare Improvement recognized that they didn't hold expertise in that area around working with Indigenous communities. And so they had reached out to First Peoples and Thunderbird, and we talked to them about the framework and about shifting language. And so we shifted the language from suicide prevention, which is very deficits-based, to one of life promotion. And I have a couple of stories about how that shifted in a number of ways, but the service delivery was getting them to think about what are we investing in from a service delivery, instead of investing in suicide prevention and deficits and the challenges in our community. How can we invest in the strengths of our communities to promote life and to improve overall well-being of our communities and our nations? The Promote Life Collaborative, as I said, really started with talking about shifting languages to strengths-based and really coming from that Indigenous lens. And so we talked to them about the framework. We talked to them about a program that is known as Feather Carriers, which is more about investing in life promotion as opposed to something like the Assist program, which is a suicide prevention program. And we, the collaborative invited these non-Indigenous organizations to come and learn about this. And they had, when they came to the table, we challenged them and said, if you're going to do this work, you can't just say, we know what we're going to do, and we're going to knock on the door of the local First Nation or an Indigenous organization and say, hi, we're here to do suicide prevention. And so we challenged them about how to work collaboratively with Indigenous organizations. So we asked them, do you know who the First Nations or Indigenous partners are? Do you know how to engage them? Do you have relationships with them? And they have to be at the table to do this work. You can't do it without them, because if you are trying to do it without them, then this isn't the collaborative for you, because it needs to be community owned and community developed. And so I think they had started with about 12 who expressed interest. At the end, we had 6 of them. And this is one of the 6, and this is the Mama Wessing Health Services, which is out at the Tribal Council in the North Shore in Ontario. And they had a program known as Nondwe Nojmowin. And Nondwe Nojmowin is a program that addresses trauma. And they worked with the local health integration network. And this local health integration network in northeastern Ontario, they identified that the Tribal Council and the health services would take the lead in using this program, this trauma-based residential program that builds capacity, so it treats or helps people to address their trauma, and then they support people to become peer support leaders, and they then facilitate this program on learning about the impacts of trauma, coping with trauma, and healing from trauma using a number of cultural approaches. And so the LIN took a very much a backseat approach, allowed the health services to be the lead, or I don't even think that's an appropriate word, but they noted that they were not the ones to take the lead. And they even flowed the money that came for this project directly to the organization instead of being the holders of the funds. And so really did that. And it allowed them to invest in other programs. And so they have a Manoba Modsman program through their social services program. And I just showed here a short description about how they use culture and look at identity as a way of attending to social health needs of individuals. So it helps them with life skills, cultural awareness, building identity, and looking at alternative ways to living a healthy lifestyle and dealing with stress. So really investing in the vision of the health services and the tribal council around cultural practices to attend to well-being. There are also some policy examples that I'd like to share. The first policy example was really the development of the framework. What we knew was there had been a lack of First Nation having a leadership role in the development of a framework. And we knew that without having a clear approach to First Nation policies, that we were seeing not great outcomes in our communities around the programs and services that were being delivered. You know, some communities had some positive outcomes, but overall we were still seeing high suicide rates, high substance use rates, all kinds of things. And so we really talked to the government about doing things differently. So this was one of those new approaches to doing business differently, where the government needs to be working collaboratively and co-designing and co-developing the work that they did. And so bringing First Nations leadership to the table, engaging in dialogues at both regional and national levels to understand the issue and to design a program or a framework or whatever it might be, and then using all of that to identify that mandate for change and co-creating a policy development process. So how do we change what's happening? And so the framework is something that is being used to change policies within the First Nations and Inuit Health Branch. And so those policies have included things like communities being able to take money and instead of having to use it in ways the government says, they are able to say through their contribution agreements, far more flexible contribution agreements, to say we are going to use this money in this way to support well-being in the community. So that policy development piece is the government not being prescriptive in the use of the funds and allowing communities to use it across, their programs and services in ways that meet their priorities. Other practical applications include things like the community-based planning guide. This guide is used by health directors. It was developed shortly after the framework was created, and so they use some components of the framework to think about how they could plan for programs and services using the key elements of the framework. And so it allows for a tool that is based on a First Nations lens and worldview, as opposed to the government identifying how they have to plan programs and services. The core concepts of the framework around community development, around developing competent services, capacity building, quality care systems, all of those main pieces of the framework have been used by Indigenous Services Canada in the development of their strategic plan. So in, I think around 2015 or so, was the first time, believe it or not, that the Indigenous Services Canada, or at that time Health Canada, actually developed a strategic plan. They had never had a strategic plan. And so they use the framework as a way of looking at their strategic plan. And so it hasn't been used just for mental wellness. They've used it in chronic disease. They've used it in maternal child health. They've used it in community health nursing. And so they've really used it across the span of health services we find in our First Nations. And so it's the framework has been used to help Indigenous Services Canada think differently about how they work with First Nations communities. Back to Promote Life Collaborative, from a policy perspective, we also saw that the framework and getting these non-Indigenous health organizations to recognize that they had to invest in the key elements of the framework to do things differently around life promotion, we saw some policy changes. And I'll tell you two quick stories. The first comes from Churchill, Manitoba. This was one of the 6 teams that were created in Churchill, Manitoba. It's not a First Nation community, but the majority of people who live in Churchill identify as Indigenous, either as Métis, some as Inuit, as well as Dene and other First Nations groups. And so they had an interest in working together around a life promotion project. And they, up in Churchill, have an overabundance of snow goose, and they were talking about harvesting them because they were overabundant and it was causing challenges in their ecosystem. And they had also identified that there was a risk of young people that were high risk young people around sort of harmful behaviors, whether that was self-harm or substance use or even involvement in the justice system. And so they wanted to engage these young people in more life promotion related activities. And they wondered if there was something they could do around the snow goose and how to attend to that. And so the young people did express an interest in learning sustainable harvesting practices. And so they talked about bringing these young people out on the land to harvest the snow goose, and then they would bring them back to the community. They would teach them how to clean the snow goose, how to prepare them, and then have a community feast. And so when they did that, or when they were proposing to do that, this non-Indigenous health organization who held all the funds, they had to go to them because one of the things they had to do was they had to purchase guns in order to harvest the snow goose. And there was a real pushback by the health organization about buying guns. In fact, they said something along the lines of, are you telling me you want us to purchase guns for suicidal kids? Like, that doesn't sound like a good idea. We're not going to do that. And so there had to be a number of conversations by those within the non-Indigenous health organization, including their Indigenous partners, to talk about cultural practices, the importance of sustainable harvesting, how it could support strong cultural identity, pride in culture, all of those kinds of things. And so they were able to shift this non-Indigenous health organization's policy, and they eventually agreed to purchase the guns. And they went out on the land with the cultural knowledge holders, and they learned how to harvest the snow geese. And they came back to the community and they had this huge feast, and all kinds of people from Churchill came and had a feast. And so they did a policy shift, and it really supported the young people to feel like they had some purpose and meaning in their life, right? That they were contributing to this big celebration in the community, and this wonderful feast. And they got a number of teachings from it. One of the other things that happened here, and it's not necessarily a policy thing, but I think it's really cool, is all of these teams were supported by coaches, and they had a Métis coach and a First Nations coach who both lived in British Columbia, but they had come to support the team. And when they started doing this work early on, people would come, but nobody was speaking their language. And so the Métis elder often would do the about prayers and things like that. And so at that feast, somebody came forward from the community and said, I would like to say the prayer today. And so they started to invoke their cultural practices by others. It wasn't a young person. So it kind of created some momentum within the community. And by the time the collaborative ended, because it was an 18-month collaborative, people in the community were also coming forward to say the prayers in their language. So they were starting to bring back language revitalization as well. Then my second story is around Alberta. In Alberta, they also made a policy shift. In Alberta, I forget the name of the region, so I apologize, but it was around the Fort McMurray area, and it was during the times of the forest fires. And so there had been a relationship developed between the non-Indigenous health organization and the local First Nation community. They had been working on some life promotion activities. One of the partners in the non-Indigenous health organization was sitting in on a planning table around emergency management planning for the forest fires. And during that conversation, it was identified that that local First Nation was likely going to be evacuated. And so the partner had heard that the province was going to give the community less than 3 hours in order to evacuate. And because this community is semi-isolated and many people spend time on the land, the partner spoke up and said to the planning table that that wasn't enough time. They had a relationship and they knew that the community needed more time to gather all of the members and make sure everybody was safe. And so after some negotiation, they were able to get the province to agree to giving them 3 hours notice, but nothing more. And they were quite uncomfortable with that. And so they went home because it really bothered them. And they talked to one of their partners late that night and said, listen, I'm really bothered. I know that's still not going to be enough time and I don't know what to do. And their partner said, you know, this First Nation, they are our family and we can't leave them to not be prepared. So we have an obligation and a responsibility to inform them, even if the province won't do that ahead of time. And so because they developed relationships, they had access to the chief in the community. And so they spoke with the chief, they told them what was coming and when that was going to happen. And the chief was able to mobilize him and his frontline workers, go out into the community, into those bush camps and get people back into the center of the community. They also were able to plan how they wanted emergency evacuation to look like, because many times First Nation communities are just told you're evacuating and you're going here or you're going there. And I know we're out of time, right, Roy? Okay, I'm almost done. And so the community was able to plan, and they contacted the province and said, when we are going to be evacuated, we want to go to this town all together. We want to stay in this hotel so it can protect our community members from being vulnerable to drug use, like to drug dealers or to people who might be trying to traffic our young people. And we're going to establish community activities. We're going to bring in our country food and doing all of our traditional practices. And they kept people together. And it was a far more supportive and safe way for this community to be evacuated. So a really good example of how they use the framework to support policy change, because the community was able to advocate and negotiate for a different way around emergency evacuation. And I'm not going to go into this, but I'm just going to leave it up and note to you that there are practical applications at a systems level, things like tripartite tables, the First Nations Health Authority as a whole different system. FNIB was moved out of Health Canada and into Indigenous Services Canada as a result of the framework, so that it could be in a more holistic way of planning and looking. And then we also supported some demonstration projects, including Elsipogtog and Six Nations, who looked at how they could use the framework around cultural safety and policy and programs and evaluation. And so we also did it in funding. And so there are some funding models here where you see that using the framework was done to create funding opportunities from our lens and worldview, including flexible funding arrangements with provinces and territories coming together to support programs and initiatives like mental wellness teams in Ontario. They brought their funding together and demonstration projects. And I thank you for your time. Miigwech.
Thank you for that wonderful presentation, Dr. Restoule. Unfortunately, we are out of time. So if you have any closing remarks or anything like that, or if not, we can just ask Clay to close us out in a good way, please.
I'm good. Thank you, Roy.
Miigwech. Clay?
Oh, Miigwech, thank you. Thank you for your presentation. Very informative. Sounds like amazing work that you guys are doing in your community. So miigwech to you all in your community, and happy holidays to you and your community. And hopefully we'll see you in the new year. With that, I just want to say miigwech. And I know the time is ticking, so I'll just say miigwech. I just want to say thank you to our ancestors for being with us in a good way, in a kind way. And I ask for, again, just for the blessings for all of us in a good way, in a kind way, in your community. So miigwech, Pamapi. See you when I see you.